So, good evening, everyone. I'll be talking about one of the important diagnostic tool used in anterior segment today, that is specular microscope. To start with, it was invented by David Morris in 1968, and it is a non-invasive photographic technique which is helped to visualize and analyze the corneal endothelial morphology either in the clinic or in the eye bank setting. So in clinics, preliminary assessment of the endothelium, it can be done with specular light reflex as seen here using slit lamp. As we all know, among various illumination techniques used in slit lamp, specular reflection is one among them. It is based on the principle that when angle of refracted beam of light makes an equal angle with that of the incident light, then the endothelium can be easily assessed. So most of the incident light on the cornea is generally transmitted. Only a small proportion of it is reflected due to change in the refractive index at the endothelial aqueous interface. And this reflected light, which can be used to visualize the endothelium. So all we have to do for specular reflection is we have to adjust illumination system such that it matches the first Purkinje image on the cornea as seen in this picture. So this is generally achieved by placing slit beam at 50 to 80 degrees angle from microscope. That is illumination diaphragm should be kept at 30 degrees on one side from the center, and observation system microscope is kept at 30 degrees away from the center. And the prerequisites we have to set the slit width at more than 1 mm. Slit width should be more than 1 mm and magnification should be at high. And view should be monocular to best visualize the endothelium. And so when the slit beam matches with the bright reflex, then endothelium can be visualized as seen in this picture. So this is a small video showing specular reflection of the corneal endothelium, highlighting the corneal endothelium here. And this is the bright reflex, which falls on the epithelium of the cornea. Similarly, based on the specular reflection principles,
Dr. Tulsi, I'll interrupt you for a moment. I was just wondering whether we can record, because we have a very high quality slit lamp. I'll appreciate if tomorrow or day after you just try to record a video of how we can do it on our own slit lamp and see if it works.
Yes,
okay. Because it'll be interesting to see if we can all kind of do it ourselves, and then we can probably, it'll be nice. Okay, thanks.
Yes. As I said, similarly, based on specular reflection principle, specular microscope also works on optical reflection technique, where the slit of light is focused on the corneal endothelial surface in a mirror-like fashion, and the refracted light rays are focused onto the film plane or camera for viewing on a real-time monitor. There are many types of specular microscopes. They can be divided into horizontal and upright. And horizontal microscopes, specular microscopes, are generally used in our clinical setting, and upright microscopes are used generally in eye banks. There are two types of specular microscope, contact and non-contact models. The contact instruments have objective lenses and they applanate the corneal surface. So during applanation, the cornea is flattened, hence the image range seen by the image range seen by the specular microscope.
I think we all have to mute ourselves, please.
Yeah, I'll repeat it. So there are two types of models in specular microscope, contact and non-contact models. Contact instruments have lenses which applanate the corneal surface, and during applanation, the cornea is flattened and the image will be enlarged. So more cells can be analyzed using contact specular microscope. And resolution is also high in contact specular microscope. And the one used in our clinics is non-contact and horizontal, which is easy to use and it doesn't require any coupling agent as required in contact microscope. Though a non-contact microscope looks at small areas, multiple areas of cornea can be analyzed using this. So there are microscopes, specular microscopes, which are available from Konon, Topkin, Tommy, and Nidec. They can be, they have either automatic imaging focusing technology or manually operated. The one we use is Tommy EM4000, which is a non-contact, and it has both automated and manual focusing technology. So with the specular microscope, we tend to see normal corneal endothelium, which appears as a regular array of endothelial mosaic, where the endothelial cells are approximately same size and shape as seen here. So endothelial cell count is generally measured as cells per square area, and at birth generally they range between 3000 to 4000 in number cells per millimeter square, and at middle age 2500 they are in the range of 2500 cells per square, and in the old age 2000 cells per square. And when the count falls below 500 to 800, it leads to compromise of the cornea or potential corneal edema. So when there are changes in size, it is termed as polymegathism, and when there are changes in shape of the corneal endothelium, called as pleomorphism. Normally, 60% of the endothelial cells are six-sided. If there is any deviation in the shape, it is called as pleomorphism, as I said. And it is seen here. Pleomorphism, it is change in size, shape of the endothelium, and change in size of the endothelium. As we can see in the picture, there is bigger size of the large size of the cells in the picture, which is called as polymegathism. There are two types of analysis of corneal endothelium, that is qualitative and quantitative. In qualitative analysis, we generally see for the abnormal endothelial structures, and also classify them into grades. For example, guttae. So gutta, they are derived from the Latin word called as drops, which are generally excrescences of the collagen. This is a specular endothelial picture showing guttata. So these are excrescences of the collagen produced by stress corneal endothelial cells. And there are normal excrescences also seen in young individuals called as Hazel-Henle bodies, which are also small transparent growths on the posterior surface of the Descemet's membrane, seen generally in the far periphery. When similar changes are seen in the central cornea, they are considered to be pathological and referred to as guttata. So generally, these guttata are seen in pathologies like Fuchs endothelial dystrophy, inflammation, and also with aging. So these are the pictures seen in these are the pictures from confocal microscopy, which best illustrates the pathologies. So in guttata, as I said, these are excrescences of the Descemet's membrane that destroy the surrounding endothelial cells. In pseudoguttata, generally, it is also caused by inflammation, infection, uveitis, which leads to cellular edema and formation of excrescences of the endothelium itself. And in endothelial blips are nothing but which occur due to contact lens wear and anoxia, and they also appear as dark spots like guttata and pseudoguttata. Endothelial denudation is absence of endothelial cells, but Descemet's membrane is retained. But in guttata, generally, Descemet's membrane excrescences arise from the Descemet's membrane itself. Here, as we can see in the picture, guttata or hyporeflective spots without clear borders and have a white hyperreflective dot in the center. And in pseudoguttata, they are with clear borders or not present in pseudoguttata, and they are also hyperreflective, but white dot will not be present in the center. And in endothelial blips, we have clearly defined cell borders, and also we have hyperreflective dot in the center. And in endothelial denudation, it is a sharply defined hyperreflective hole without any white dots in the center. So this is a microscopic picture showing that guttata does arise from the Descemet's membrane. And pseudo gut data doesn't have any Descemet membrane disturbance, and also endothelial denudation doesn't have any Descemet membrane disturbance. Coming to the methods of analysis of endothelium by specular microscope, we have fixed frame method of analysis, corner method of analysis, or variable frame method of analysis, and center method analysis. In fixed frame analysis, which is shown here, this type of analysis counts all the cells within the frame, and this type of analysis, it adjusts for cells which are extending outside the frame. As we can see here, there is 50% of the cells which are falling at the edge of the frame. 50% of the cell is falling inside the frame, and 50% is outside the frame. So whichever cell is partially present inside the frame, this is going to be counted as full cell. And in variable frame analysis, the borders of the entire group of the cells are outlined with the help of specular microscope, and it appears as if there is the edges of the cells, or border of the cells appears irregular. And this method of analysis is more accurate than fixed frame analysis, because the machine doesn't count partial cells. Instead, it considers entire cells at the edge of the frame. And coming to the center method of analysis. In center method of analysis, we have three types: automated, semi-automated, and manual analysis. In automated analysis, generally the machine is set to default cell size. That is, only it can analyze a small size of cell. But in semi-automated analysis, the cell size can be manually selected from small cells to large cells. And in manual analysis, again, we have two methods called as center method and flex center method. In center method, the center of each cell is marked in the contiguous group, and software then counts the number of cells by determining the cell area from the polygon, the entire polygon. And in flex center method, the outer boundary of all visible cells, as seen here. So this is the center method, where we can mark the center of each cell and analyze it. And in flex center method, the outer boundary of all visible cells can be outlined by using a arrow, and we can just analyze the area where we marked. So center method is generally used to assess donor corneal tissue, and flex center method is used when the number of cells is very less, endothelial count is very less. And generally healthy corneas, we generally use a full automated analysis to analyze the healthy cornea. So having said that, now let's go into the various quantitative parameters in detail. First is cell density, which is defined by number of cells measured per mean cell area. And any insult to the endothelium, it can cause decrease in the cell density. And coefficient of variance is defined as standard deviation in the cell area divided by average cell area, which indicates polymegathism. And causes of polymegathism can be long-term contact lens wear, diabetes, and after cataract surgery, and any penetrating keratoplasty, or any inflammation, or also with aging. And normal value range is between 30 to 40. And percentage of hexagonality is calculated as the number of hexagonal cells divided by number of cells counted. Normal range of a percentage of hexagonality, also denoted by 6A, is more than 50 to 60. So this is the machine Tommy EM4000, which is available in our clinic. So while using this instrument, patient is explained first about the procedure to ensure maximum cooperation, and after that patient particulars are fed, and then the patient is positioned properly in chin and headrest. And we ask the patient to fixate on the blinking light inside the instrument. And fixation target can be focused with finger touch, and instrument automatically measures the endothelial mosaic and generates the parameters. This is how the endothelial mosaic is measured in our clinical specular microscope EM4000. The system automatically captures multiple images, and the best image out of this shots is automatically selected, and it is displayed on the screen. This is how the final image looks like in the monitor, which shows right and left eye both parameters. So this is how the printout looks like. And while reading the printout, the most important parameters to be assessed is cell density, which should be between 2000 to 3000, and average size of the cell area, which should be 150 to 350 micrometer square. And coefficient of variance, as I said, it should be between 30 to 40, and which indicates polymegathism. And 6A, which is a percentage of hexagonality, should be between 50 to 60% at least. And also, machine also analyzes corneal thickness too. So when you see individual eye, there are two histograms which are present below these parameters, which also indicates polymegathism and pleomorphism. So when the number of cells, when the highest number of cells falls between 300 to 400, it is considered as normal. And when assessing for pleomorphism, when the highest number of cells falls under 6A, then it is considered as normal. So the special features for EM4000 Tommy used in our setting is it has auto alignment and auto shot, and it has integrated non-contact pachymetry, which can measure the corneal thickness, as I said, and it can count up to 300 cells per frame. And it has multiple measurement areas, which I'll be showing in the subsequent slide. And it is very fast, and also has a large color touch screen, and thus producing a more morphology and density diagrams in the printout clearly. So this is how the measurement areas where the instrument measures looks like. And first, machine measures in the center, and also six paracentral areas at 2 mm, and also six peripheral areas at 5.3 mm. So the image of the corneal endothelium can be displayed with cell shapes, which can be traced like this in different color, as well as with different areas and structural forms of cells, which are displayed in different colors. So basically, by providing details in different colors helps to helps us to it provides a better visual understanding of the condition of the corneal endothelium. So in new EM4000, we have another method of analysis called as L count analysis. And also this machine has a built-in printer also, and it stores about approximately 16,000 patient database. The difference between earlier generation EM3000 and present EM4000 is the database, large database storage, and built-in printer, and monitor size is a bit larger in EM4000, and monitor tilt option is also available in EM4000. So now coming to the various applications of the clinical specular microscope, most important indication is early diagnosis of Fuchs endothelial dystrophy. And also we can assess the endothelium before cataract surgery in cases where there is history of previous trauma, and in advanced hard cataracts, and pseudo exfoliation, recurrent uveitic conditions, and corneal edema present in the contralateral eye, and also with a clear graft when we are planning to operate for the cataract with a PK, and glaucomatous eye with cataract and subluxated lens when choosing an IOL, and also other conditions like posterior polymorphous dystrophy, IC syndrome, and congenital glaucomas, and also for the evaluation of donor corneal endothelium for the grafts, and in the assessment of corneal endothelial assessment in after refractive surgeries, and phakic IOL implantation after collagen cross-linking, and contact lens wearers. To conclude, I would say that specular microscopy is a simple and valuable tool for evaluation of endothelium in normal and also diseased eyes. It is very critical to perform as per the standard guidelines, and also clinico-specular correlation is very important, which helps in making accurate diagnosis of the condition, which assessing the especially the functional reserve of the cornea, and also it has a very good application preoperative evaluation for surgical management. Thank you.
Thank you, Dr. Tulsi. I had a question for you. Like the previous version of the specular microscope that we had, I used to find that in corneas which were decompensated and which were not doing so well, we would artificially get a higher endothelial count for some reason. And this current model that we have, I've not seen that as yet. And I've also seen that we have a color coding now of the cells. So do you know that if that also is a difference between the previous model and the latest model that we have?
So the latest model, what I observe is there are two types of analysis called as trace method and cell method, where we can mark the cells. Basically, the endothelium which is compromised will have less number of cells. So the area where the good amount of endothelium is present, we can focus there and select the cells with the center method and analyze that particular area. So that option is available in this instrument.
Right. But I think if you go on the auto mode, then even on the auto mode, we never used to have this color coding of these cells, which I see in this current model. So is I think that may be an advantage also of the newer model. And
Okay.
previously we used to get fictitious high readings in grossly decompensated corneas, which readings which did not make any sense at all because of the gross polymorphism and pleomorphism that was there. So, but
Okay.
till now I have not seen it in the newer model. So maybe Dr. Ruchika can tell us that because we used to encounter that before.
You're
Uh,
absolutely right, Saurabh, and I think Dr. Ruchika can guide us because this slide which Dr. Tulsi has put actually makes it very clear how we can use the manual function on this machine as compared to, our previous machine where all these options are not available. Dr. Ruchika, can you help us?
yes, I would just like to make a comment that basically that is the drawback with the automatic analysis. Like she mentioned in her initial slides, that when we are doing an automatic analysis, it is by default programmed to kind of capture the S size cells, that is the standard or the smaller size cells. But in a diseased cornea where there is significant pleomorphism and polymechanism, so when we do an automatic analysis, it tends to overestimate the number of cells. So ideally in a diseased cornea, automatic method is not really ideal, because yeah, so you can see here in the top line it is given that automatic analysis, the default cell size is S. So in a diseased cornea, it is better to do a semi-automated or a manual count, because then you can adjust the cell size accordingly. Like if you have, you can make it like medium, large, or XL depending on what kind of cells you're seeing, and that would give you a more accurate count. And of course, the added feature in the newer or the 4000 version of Tomy is the color coding. So that, like any other of our colored printouts like Pentacam, like a colored visual just gives you a very quick way of analyzing that what is the variation in the cell size and shape, because the larger cells will be like maybe a darker green and the smaller ones will be a lighter shade of the green. So that just gives you a quick analysis of what kind of pattern you are looking at. Also, another drawback of the specular when you're looking at diseased corneas is when there is significant epithelial irregularity or stromal haze, a large amount of the light gets reflected off. So basically, you don't get any imaging of these cells at all, endothelium. But that does not mean that there is no endothelium at all. There will be a few cells, but they just can't be seen on the specular because most of the light is reflected off the surface.
Okay, thank you so much for that explanation.
Dr. Ruchika, in such cases where the specular cannot visualize the endothelium because of poor clarity or the cornea not being very healthy, do you think the clinical method is much superior and can still help you, or what else can you do in those cases, like where
Yes,
you are
sir.
finding that?
I mean, so all said and done, we have to correlate clinically at the end of the day because, as discussed already many times, we get an overestimate of the cell count, but clinically the picture looks quite different. So we have to correlate clinically always, and in more advanced cases, specular is not really useful. Just like advanced keratoconus, where where there's significant scarring in the pentacam is of no use really. So same case happens with the specular. When the cornea is really bad, specular really doesn't help.
Also, the machine has those different modes of capturing in the six different gazes of I mean, you can have the central, and then you can have those supranasal, supratemporal, and then intranasal, infratemporal, and then superior and inferior. So when do we get to use those? Like, how can we when would one utilize those?
Uh, I'm not really sure because, sir, to be very honest, the peripheral counts really don't matter much because unless we are looking at very early stages of like a Fuchs dystrophy where we are considering things like desmetorexis or something like that, because then if your peripheral count is more than 1000, then it is said that if you go ahead with a desmetorexis, the remaining endothelium can actually cover and recover for the central, because in most of the diseased cases the central cells are affected initially. So in the early cases where you're considering a desmetorexis or something, then if you get the peripheral counts, you can actually make a decision if you're planning a surgical intervention. Otherwise, I really don't think where like a peripheral count can be helpful. Like that's the only thing I can think of.
Also, I wanted to know that typically following a cataract surgery, an uneventful cataract surgery like a phaco or something, how much of a fall in endothelial count should we expect? And also, like over the years, like a phakic or a pseudophakic eye would have some fall. So will that fall be more as compared to a healthy eye of the same age patient? Which means that suppose does it get accelerated following one insult, or it like goes down and then it follows the same pattern as the age related pattern would do? These have been a few things on my mind. And also post phakic lens, I know that cell counts fall much faster initially for the first 2 3 years, and then they kind of fall according to the age. So cataract surgery, I'm not sure if you're aware, Dr. Ruchika.
Sir, I'm sure, like, I'm not aware of, like, possibly studies, but yeah, I am sure that any kind of surgical or iatrogenic insult definitely accelerates the average cell loss, which is around, I think, 0.6% per year if we consider the average cell loss. I think any kind of an iatrogenic or surgical intervention does accelerate that, also depending on lot of other factors like, I mean, how the surgery is done and what are the other, in fact, like if the patient is diabetic and lot of other factors associated with that, mm, I think can definitely increase the average cell loss.
Right. One last question from me. One of the slides which Dr. Tulsi showed of the capture of the screen from the machine, at the bottom it showed central corneal thickness from the specular, and also another one from the ultrasound. So I was intrigued as to what that might be. In this, no, the previous one. Yeah, if you look at the bottom, there is a CCT which is normal. I mean, and then there is a CCT US, which is little more. I was wondering what CCT US is. I don't know if any of us knows about this.
Even I'm not sure, sir.
I just happened to notice it today. I mean, when she was showing this slide, and I was wondering what this might be. We'll find out tomorrow. So I'm sure others will have questions, and I've taken away almost so much of the time. So if anybody else has any thoughts or questions or suggestions or inputs.
I have one question, Dr. Tulsi.
Yes,
In uveitis, like in confocal microscopy, like suppose for CMV, anterior uveitis, then we can maybe see like those typical owl-shaped cells. But here, is there anything in particular that we can use?
uh, in specular microscope, definitely we can see the changes in specular microscope also, ma'am, but it will be more evident in confocal microscopy, I guess. But definitely, I think we can differentiate between Gattaca and pseudogattata because in pseudogattata, we don't have damage in the Descemet's membrane. So the dot which appears in the center will not be so prominent as seen in the Gattaca. That's
Okay.
what I have read.
Okay.
And
Okay.
I can show you the picture of that. So in Gattaca, the white center will be very prominent. In pseudogattata, will not have that.
Okay. And is there, I mean, anything that we can use in cases of uveitis, like maybe for KPs or something? Like we've had some cases of I think Posner-Schlossman syndrome, or one or two cases which had like really high IOP but not too many KPs, and ultimately they underwent TRAB. And in fact, in one patient we did like an aqueous tap, but that did not show any viral etiology. If there is anything that we can use in for from this, then if you can let us know later, then that will be good.
Sure, ma'am. I'll let you know.
Yeah. Thanks.
I think what Dr. Shweta was referring to was, Dr. Padma Malini's work at Narayan Netralaya.
Right.
So
Yes, sir.
on confocal, she has, shown in Fuchs cases and in Posner-Schlossman, CMV, because of cytomegalovirus, you have those owl-shaped, things seen on confocal. But I'm sure that is much higher resolution than the, the specular. So,
Right.
that can be made out only on the confocal.
Yes. Yes, sir.
Sir, Abhijat has a question. Does the peripheral cell count affect the decision to make phaco incision in any manner, as in type and location of the incision?
So I think the Dr. Gaurav can take that question.
Yeah, I'm not aware of, we've never done that. So I'm not sure if that has any significance because we don't typically kind of look in the periphery at all unless there is a reason to look. So I don't know. I don't have an answer actually. So I won't be able to give anything useful here. We can look it up actually.
So, because if the peripheral endothelial count, if it is less, if at all, if it's less central and peripheral, then generally we tend to opt for SICS rather than going for corneal incision or going for a phaco. So I think anyway the incision will not be on the cornea. So that's what my thought is.
Yes, I agree. So also I was wondering whether I think Anshika is also on the meeting today, and she has a thesis which she submitted recently on how diabetes impacts corneal endothelium. So Anshika, can you tell us a little bit about what you found, like in short?
Hello. Yes, good evening, everyone. So I actually had a doubt for Ruchika ma'am that when I was researching for my thesis and everything, so we all know that endothelial cell density cannot increase after that because there is no regeneration. But there were some studies that said that on giving aldose reductase inhibitors topically to the patients, they showed a decrease in polymegathism and they showed an increase in hexagonality. So, but then no follow up was done, and these were really old studies. So, but then do we have any other similar modalities available, ma'am, that we can actually give to people to improve their endothelial health in patients who we find that, it is suboptimal?
Hello. Yeah.
Hello.
Yeah, Anshika, I couldn't hear your question completely actually.
Okay,
Yeah,
ma'am.
so
Ma'am, I'll repeat.
I think now the latest modality, the drug that we're using is Ripasudil, right? Ripatec. That is known to kind of decrease the
Yes,
attrition
ma'am.
of the cells in the early cases of Fuchs.
Hanji.
Yeah, so that is one treatment that we are looking at. And in fact, even I have started in few of my patients, but I don't have a very long-term follow-up of these patients. Like I have patients who've been using them for 2 to 3 months. And when I've repeated the specular at 3 months, I've found that there is not much drop or attrition in the cells. So, but I'm yet to see what the long-term results are.
Yes, ma'am.
So basically, all these drugs, they just kind of, it's not really an increase in the cell count, but they kind of reduce the attrition of the cells.
So, any other questions or comments from anyone?
I was, expecting Anshika to tell us about what diabetes does to the endothelium. Did you find anything, important, Anshika, in one or two lines?
Yeah, so basically what my thesis found was that there was a significant increase in central corneal thickness and a significant reduction in endothelial cell density when they compared patients of non-proliferative diabetic retinopathy versus proliferative diabetic retinopathy. So they found that the severity of diabetic retinopathy also has an effect on endothelial cell health. So my thesis basically was trying to find a correlation between severity of diabetic retinopathy and diabetic keratopathy. So that is what it discovered, that while there is a difference between diabetic and non-diabetic population when compared with controls in all four parameters, but when comparing just amongst diabetics, those with more severe forms of retinopathy showed a significantly reduced endothelial cell density and increased central corneal thickness. So, but otherwise, what we know in the spectrum of diabetic keratopathy, more importantly, it shows keratoepitheliopathy and even changes in the stroma at the molecular level. But in the endothelium, these are the only findings that were reported.
Thanks, Anshika. I think we can, if anybody else has any questions, otherwise, I wanted Dr. Ruchika to kind of give us this thing that which are the cataract surgery patients, which are planned for cataract surgery, where we should be advising a specular count, like which are those group of patients, like if we wanted to ensure. And Dr. GS is quite passionate about this as well, and if he has anything to say here.
Uh, so, sir, definitely, if you're seeing an obvious Like if you see node gatte, then those definitely need a specular. And if you're looking at hard cataracts, elderly patients, comorbidities like diabetes, glaucoma, if they are on multiple drugs. So glaucomatous patients definitely, if diabetic with hard cataracts, because most of the diabetic patients do have, the significant nuclear sclerosis. So these are the patients where I would do, even if I clinically don't see any abnormality on the endothelium, if I'm dealing with a hard cataract or glaucomatous patient on drugs, then I would definitely get a specular done.
I completely agree. Also, if anybody has had any prior surgery, that would also, you should be on guard on those patients if they've had any kind of a procedure previously, and then they're planned for a cataract surgery, like maybe even a glaucoma surgery or something else, or trauma repair or something. And even some of our uveitis patients, they tend to show endothelial cell loss. Any thoughts on that from the retina side? Like, is recurrent uveitis risk factor for endothelial cell loss? And in what way? Like, when should we be more careful? Should we be looking at them in some different way?
We are not doing specular counts in uveitis patients, so maybe that is something which we can look into. I'm sure it must be affected because the KPs are the gross things which we see on slit lamp. So I'm sure the endothelium also must be getting affected, and that would be an interesting kind of thing to look at in uveitis patients.
Great. So I think if anybody else has any questions or suggestions, and otherwise we can close.
So in contact lens wearers, how periodically we have to check corneal endothelium status?
I think that's again a very good question, and I don't have an answer to that, but maybe.
Uh, I think with the like the newer contact lenses with high decay and oxygen permeability and daily disposables, that's not really much of a concern. I think that was more of a concern when we were dealing with extended wear or things like that, where people. Now, I don't think that's unless, especially clinically, if you're not noting much, but I guess a baseline specular or doing it once a year is okay, but I don't think it's really required.
Great. So I think today's class was excellent, and I think very useful information for all of us, and very well presented, Dr. Sri. It was very informative, and I think a very healthy discussion, as from whatever we heard, and I'm sure all of us have learned a lot, and will be able to implement this better in our practices
So
and
before,
interpret our speculum. Yeah,
yes,
yeah.
before
Please go ahead.
ending, I would like to just mention a point about future prospects, which I found in literature that generally the limitation for the specular microscopy is we cannot apply in community and pediatric eyes to examine them under anesthesia and supine position. So there is a smartphone-based endothelial imaging which is coming up to overcome these limitations. Just wanted to add that thing.
That should be very interesting. That's really nice. So I guess
Just,
that brings us to an end, and I think
I just want
next
to make a
Tuesday.
comment, sir.
Yes, please, Dr. Das.
Yeah. So one of the one of the biggest indication of specular when we deal with drop nucleus, drop IOLs, when we have to intervene, with a bad cornea just settling down with steroid and all, then taking out in the anterior root from the lifting it from the retina, it's a big challenge actually. So that's one of the indication of doing specular in those cases, because it takes a long time for the cornea to settle down before we take up the case, and during the case there's so much of handling. Earlier, I think we have operated in certain cases of 800, 900 counts, very bad corneas. But what I've observed is that if I make a scleral tunnel and approach, and while bringing out IOLs or the CTRs or whatever, and somehow and putting a SFIL again when the chamber fluctuates, we don't have any control. Rather than going by clear corneal incision and putting sutures, it's always better to go by the scleral tunnel because the approach is little below actually. Somehow, the cornea doesn't decompensate. But again, I think a pure indication of specular induced or those sort of cases basically. But I just wanted to know whether we should do the specular when the corneal edema is going down, the SK is little less, and just prior to the surgery, or should we just do it in the patient presence and subsequently monitor it before we take up the case? Any comments, Ruchika?
Sorry, sir, I didn't get your question.
Should we do the specular when the patient presents to us with corneal edema and SK, or after giving steroid and controlling the IOP when the things becomes a little bit, ready for the surgery, then we should do it. Whether we should do it or we don't do it. So that's that I wanted to know.
Sir, definitely. I mean, if there is some evidence of corneal decompensation and we are planning a surgery in the future, definitely a baseline specular should be done so that we have our guards up and we know what to expect, and more importantly, to counsel the patient. That's most important. Like if we are dealing with a compromised cornea and we do expect that it can decompensate further, it's very important to very helpful in prognosticating and then counseling the patient, because many times we have unexpectedly like surgery goes fine and then next day we see edema and we are also surprised and it's hard to explain to the patient. So more importantly from that point of view, especially when we are doing just straightforward surgeries like cataracts and we note that the endothelium is compromised, at least we can counsel the patient so that like both patient and the surgeon is prepared what to expect.
Right. But one thing just I wanted to add that again, a basic steps like whenever I do this kind of cases, I keep injecting visco in each and every step.
Right.
Even though it's very difficult because the fluid comes from the pars plana root and it continuously keeps on flowing through the main incision. And so much of handling, putting the IOL, taking out everything. But even I believe if we approach with a scleral tunnel, then and keep on putting visco, the some amount of cornea stabilizes even after the surgery. But sometimes it really goes very bad. Everything is done and set, but cornea goes away.
So I
Right.
think, Dr. Das, you made a very valid point, and also about the fact that a scleral tunnel would be definitely more protective than a clear corneal incision because it causes less endothelial damage. So regarding that point that you made, where there's continuously you need to keep replenishing the viscoelastic. So maybe in such cases where you anticipate a lot of handling, it may be a good idea to at the start of the procedure itself inject viscoat to protect the endothelium, and it stays sometimes even after 15-20 minutes towards the end of the procedure. You'll find that a
Right.
thin layer of viscoat is always present along the endothelium, and it just doesn't go away unless you actually go and aspirate it. And in fact, it's a couple of times that I've had to actually been very dangerous to remove the viscoat, which is sitting very close to the endothelium. It doesn't get absorbed, kind of aspirated unless you go very close with your aspiration port. And sometimes I've actually injured the endothelium because I went so close that trying to remove the viscoat that it, kind of touched the endothelium, and I felt horrible about it. So there is that very good protection from viscoat in such cases. If you, however, you have to use it before at right at the start of the procedure, then it coats it nicely. If you try to put it during the surgery, sometimes it won't. It'll just go deeper, and your, especially if the PC is not intact and you have a vitrectomized eye, your viscoat will end up going into the vitreous cavity rather than protecting the cornea really. So it has to be used right in the beginning.
Right, sir.
So I think we've enjoyed the class today so much. Thank you so much, Dr. Tulsi, for presenting nicely, and for all of us to participate in the discussions, and have a wonderful evening tonight. And hoping to see you again, all of you, on the class on Tuesday. And we were considering also to move the classes on, instead of online, we could maybe do physical meetings starting with at least once a week. And I would love to hear from everyone on the group, on the WhatsApp group, what time might be most convenient to organize a 1 hour physical meeting once a week at least, and then we can continue with one of them as online, and then later on see how things go. So please, let us all express our thoughts. So thank you so much for the nice meeting and a very good night. Unless anybody else wants to say some last few things.
Yeah, I think it's okay. Good night. Thank you.
Thanks everyone for joining.